session, so please kindly assemble all delegates. We're starting the session. All delegates, please kindly assemble.
I'm only reading this side. That side is my sister's music lessons. So we'll yes, okay.
Welcome back, everyone.
Sandhya madam she is having some medical issue.
Okay. Okay. Welcome back, everyone. Indeed, nothing like a tea break to serve as an apt stress buster after all that expansive food for thought we have been assimilating in our first session. Recharged and ready, let us move on to our second session, which will deal with continuing care of neurotrauma patients with such aids as nutrition, physiotherapy, infection control in the ICU, and rehabilitative care by specialist neurotrauma nurse. To chair the session, personally as an alumnus CMC Vellore, it gives me immense pleasure to firstly announce and invite Professor Dr. Matthew Joseph, also from CMC, our own beloved ANS, Ms. Jacinta Gunjal ma'am, and last but in no way the least, Ms. Achila ma'am. Dr. Matthew Joseph, he is the Professor Neurosurgery, Christian Medical College, Vellore. He is also the current President of Neurotrauma Society of India, and as such, a privilege indeed for us to have his befitting presence here in our midst today. Ms. Jacinta Gunjal, Assistant Nursing Superintendent in charge Hospital Infection Control Unit, JPNATC, AIMS, New Delhi. Her awards and honors include the 2011 National Florence Nightingale Award in Nursing Division of Ministry of Health and Family Welfare, Government of India. She is trained in trauma and infection control at R. Adams Cowley Shock Trauma Center, University of Maryland Medical Center in USA in 2014. Likewise, Knowledge Co-Creation Program on Strengthening Human Resource for Improvement of Community Health held at Okinawa, Japan in 2017. She was a panelist at the National Science Center on Public Awareness of Superbugs, the End of Antibiotics, and was also selected as a role model of an infection control nurse in the educational video by National Council of Science Museums, Ministry of Culture, Government of India on Public Awareness of Superbug, the End of Antibiotics in 2019. She has both authored and co-authored in many national and international journals. Ms. Achila, Assistant Director General Nursing, Directorate General of Health Services, Ministry of Health and Family Welfare, New Delhi. Her awards and honors include 2019 National Florence Nightingale Award, awarded by the Honorable President of India, Certificate of Outstanding Services and Contribution to Improve Neonatal Care by IFPB in November 2014. She is an NRP Master Trainer, NRI TAT Nursing, Daksh trained in BPNI's training course on infant and young child feeding counseling. She serves as the National Faculty for National Collaborative Center for Facility-Based Newborn Care. She is part of the empanelment as External Quality Assessor of Public Health Facilities under the NHM and a NABH Assessor. Once again, as a fresh reminder, before our distinguished chairpersons duly announce and introduce the speakers, all speakers are requested to kindly cooperate and adhere to the predetermined time slots assigned to them. Thank you.
Very good afternoon. So we resume the session 2, and the first speaker I would like to invite Miss Richa Jaiswal. She's a dietitian and from AIMS, and regarding her awards and honors, she has got the first prize in 3 years in line from Diabetic Self-Care Foundation, and her interests are regarding the bariatric nutrition, surgical nutrition, enteral and parenteral nutrition. So she is going to have the session regarding the nurturing and nourishing nurses in the nutritional care process. Floor is yours, ma'am.
Good afternoon all. Thank you, Chairperson. Thank you, organizers, for inviting me and giving me this stage to interact with you all. With the large group of nursing personnel, and once we are in the group, it means like it is a two-way of learning. It's just not that the person who is standing the other side. To start my session, I would like to thank Sonia Chauhan and Rachel, who were like interacting with me and given me a complete guideline about my presentation, which includes the time limits, and it shouldn't be as technical as it could, it should be as simple as it could be. It shouldn't be more technical. And this topic, I personally consider it as very good initiative soon after the small snack break. So nurturing and nourishing is like where the nurses stands in the nutrition care process. To initiate, I have outlined my talk into certain topics which I will use in a different slides, like definition of nurturing and nursing, central role of nurses in quality care, role of nurses in nutritional management, impact of nutritional improvement in nutritional care process. So nurture means to take care of and encourage the growth of the patient, and nourishing means like to provide. So nurses, it seems very small words like to give counseling or to encourage the patient or to provide something, but it holds the entire treatment plan for the patient during their stay or during the counseling once they reach to the OPD. Nurse, the word has been derived from the Latin word and which means to nourish. So your central role is to nourish the patient by many means, which that doesn't mean that you have to nourish only through the food. That impacts the emotional and psychological well-being of the patients. So quality care, this I have derived from the study. Quality care, where the nurses' care is one of the major component of a healthcare services, and the nurses plays a central role in offering emotional and psychological support to the patients. So ensuring optimal care given to them is very important. Patient, they themselves perceive about the nursing care is like nurses is the one who translate information technically and professionally with a human touch. So it's just not that what we learn and what guideline we go through, giving that to a human touch means science, combining science with the art is a role of a nursing care, and that is going to that should be dealt with the every aspect of dealing with the patients. So this is this data has been taken from the same paper. I would only I would only mark these two aspects, like caring attitude and responsiveness of the nursing has been perceived by the patient more than 90%, which means a lot. And this is the Indian data. We all know why we are talking about this, why the nurses' role are very important. We all know that malnutrition does exist in our hospitalized patient, but do it exist only when they get admitted, or it is pre-existing? So our own NFHS data says that pre-existing malnutritions are among general population, which is alarming. And once we talk about the malnutrition, it goes under and overnutrition. Both, in addition to that, the micronutrient deficiency, that is another level of adding up in the malnutritional status. So without assessing these things or keeping this factor into mind, we won't be able to deliver a right way to the patients.
So it is imposes a substantial economical burden if our patient is malnourished in terms of like patient that leads to patient stress, and that is going to increase the overall economical burden on the country as well. So that increases the length of stay in the hospital, and more frequent readmission is required, as Dr. Manju has already mentioned in the in her talk. Malnutrition can pre-existing, that can be due to poor food intake, that can be hospital environment induced, and that can be disease related, that can be inflammation induced. So this is the paper which says that moderately nourished patients range from 15% in the trauma injury and 86% in cancer. Moderately nourished means this screening pattern has been done within 24 to 48 hours of their admission. So being in the trauma center, like most of us would disagree, because our patients they are prone to develop a malnutrition within few days if we don't provide a nutritional care to the patients. So role of nurses is very important to identifying the malnutrition, and an accurate screening tool should be implemented to identify the patients who are malnourished or who are at risk of malnourishment, and that too, and soon it has been identified, it should be referred to the clinical nutritionist and clinicians. As ma'am has already mentioned, then in future there would be many OPDs or clinics where the nurses are going to play a important role, or the first person who are going to interact with the patient. So once you identify these patients, these patients need to be directed at the right place for the proper assessment. This screening should have been done within 24 to 48 hours, and this should be repeated at regular intervals to identify whether the patient has been transferred from malnutritional status towards the anabolic phase. And this should include dynamic parameters including the BMI, weight loss, the food intake, and there are many nutritional tools. Like I have mentioned only 3, but there are many nutritional screening tools. But European guidelines says that NRS 2002 is meant for the IPD patient. The malnutritional universal screening tool is meant for the must, and the minimum nutritional assessment tool is more for the geriatric patient in these institutions. So nutritional assessment, after the screening, nutritional assessment is generally done by the dietitians, but being a nurse, you play a central role interacting with the nurse, with the doctor, and with the different teams like physiotherapist and all. So you should be knowing each and everything, who is coming, who is doing what, and what has been done, and where it should be well documented in the file. So even dietitians, if they are coming, they need to document each and everything what they have seen, and to assess the malnutrition by easy ways. There are certain criteria by which we can assess it easily by seeing the weight, and we can assess it by the ideal body weight, whether they fall in the category of 80% or 120%, or they have lost the weight in last 3 months or so. If they are nil by oral, then definitely if it is crossing the time limit of more than 5, these patients are at risk of malnourishment, and there along with the nutritionist, the nurses also play a major role to interact with the medical team, the complete medical team, that when and how we can initiate nutritional therapy for these patients. There are certain criteria where patients can be assessed, and some areas where the nutritional assessment becomes a very challenging case. I have learned in the neurotrauma area. I would share those things in my slides. There are certain predictive equation. I won't go in detail of this, by which we can assess. There are other means, you all might be knowing about it. This I have learned in the neurotrauma when I started my journey there. This is a predictive formula which requires the height in centimeter, waist circumferences and hip circumferences in centimeter, by which we can identify the actual weight of the patient. This could be a predictive one to analyze for the medicine doses and for the assessment of the actual energy and protein requirement of the patients. There are many additional means which should be looked after, and interaction with the nursing staff and the dietitians is required for that. You all know about it, but what I want to emphasize that the most important aspect is assessing the monitoring the patients when they are on a feed, whether they are accepting it or tolerating it or not, and that should be dealt on a day-to-day basis at bedside with the dietitian and the nursing staff. If something is not able to doable between we two, it should be definitely discussed with the other medical team, and we need to chalk out the certain plan for our patient, because we can't leave them. We know that the moment we leave these patients and overlook these patients, they will soon land up in the malnourished condition, and definitely it is going to increase the burden of the total health care. Fluid imbalance and other things should also be taken care into, and energy requirement I have just simplified. Just energy requirement, I have few slides to share, and energy requirement, this is the simplest way by which we can assess. In our setup we use the Harris-Benedict equation to assess the resting energy expenditure. These are the important aspect. As I have mentioned, that malnutrition doesn't mean only the calorie and protein. We shouldn't overlook the micronutrient deficiency among our patient. This is just a summary of what all how much nutrients are required in the initial phase, and then in the progressive days. Fluid requirements, there are certain scenario where the fluid requirements are higher, and then there are certain scenario where the fluid requirements is lower. To sum up my talk, I would say that organizational training is a must for all the staff, and nursing staff should be knowing the dietetics practices, the time of meal which has been reaching to the patient, because there are many elements of food. Is just not the calculation and the amount and the cleanliness of the food, the how warm and hot food has been served to the patient, that is also going to impact the patient. Unless or until patient feel like eating, whatever we do is going to be in a vain. So with that note, I would say that when nourishment is a pure, reflection and a higher understanding are pure, memory becomes a strong. When memory becomes a strong, there is a release from the knots of the heart. When heart and brain is working appropriately, then rest of the body part is going to align with the healthy heart and brain. Thank you.
Thank you so much, Richa ma'am. You have highlighted regarding the nutritional requirements and how the nurses play an important role in screening of the malnourished patients, and with the various tools also they can do the assessment, and it is really the nurses, they can do wonders in that if they can monitor the patients well. So thank you so much for your presentation. Thank you. Any questions, anything from the group?
Sorry?
Maybe I misheard you. You said 2 days later you'll reassess to see if the patient has gone from the catabolic to the anabolic state. I thought it took longer for the patient to develop and become more anabolic. The first few days are all spent losing energy.
Yeah. So anabolic phase, like it is, one single person can't take a call on it. So once the patient is started in the recovery phase, when the patient requires to shift, means if you ask me with my personal experience, I would say, or what literature says, once patient get transferred from the ICU to or ED department to a general ward where the less supports are required, life-saving supports are required, that phase can be considered initial phase of anabolic phase, and the easy assessment is whether they are the clinical parameters are improving or not, or the weight is increasing or not. Then there are certain other means by which we can assess our patient, seeing the fat-free mass is increasing or not. So these are the criteria by which we can say that yes, the patient has started the new journey. Thank you.
I think I will have 2-3 comments. When we were resident and Dr. Banerjee was there, they invariably asked the nurses, when you want to put a Rayleigh tube, when a comatose patient should have Rayleigh tube, when the oral feeding should be started, what are the indication of transgastric feeding, gastrostomy, and how the Rayleigh tube is put. It should be silastic, it should be plastic, it should be polymer, nasal feeding is better, oral tube is better. What happened if you put an oral tube and there is no mouth gag and patients swallow it? We have gone and operated, patients chew the thing and swallow this, and we went and removed the Rayleigh tube from stomach. So what are tips are very, very important. When to put a tube, how much to feed, what is trial feeding, what is the quality of feeding, how much water, how much milk, what is the proportion of milk with water, how much juice should be given, what caloric should be given, what the micronutrient. So all these things are matter, because if you do not give a high calorie, there is negative caloric metabolism. If you have all these things, when you fasting, when do you put a Rayleigh tube? When? Today I have accident, I am in coma, I am not operated, tomorrow will put a Rayleigh tube? When? So that those are the things which is nurses must know. What is the indication, contraindication, feeding to the stomach, and mandible fracture. It's called as fracture. We put a Rayleigh tube. 15% people have got nasal fracture, bleeding from the nose. Bleeding from the nose. Ignorant fracture, CSF rhinorrhea.
Thank you, sir.
They all see that every day. Right?
Yes, sir. Thank you.
Thank you so much, Richa ma'am, for your wonderful presentation. Thank you.
So the next speaker we have Parul Chauhan. She is a physiotherapist in Trauma Center. Welcome, Parul. So Parul has done her BSc Honors Physical Therapy with distinction from Delhi University. Experience in major government hospitals, organizing and co-organizing secretary at various physiotherapy seminars and conferences. Presented paper and posted at national and international conferences, and her interest is in research, evidence-based physiotherapy practice. So welcome, Parul. The floor is yours.
Thank you, ma'am. And a very good afternoon to everyone, to all the delegates and the distinguished faculty members present on the dais. And I would like to specially thank Mahapatra sir. Sir, I am really privileged to be making the presentation in your presence. And sir, we all are privileged to be born in the same era as you because we really learnt a lot from sir, and I would say he's, the...
Don't tell the truth. How was Saudi Arabia?
Sir, that is the way we learn. Thank you, sir. No, sir, we've really learnt a lot from you. So, on that note, I would be starting a short presentation on the physiotherapeutic care of neurological patients. So, we all know that nowadays the approach is to be a multidisciplinary team, and where all the healthcare providers work together. They are important allies. They form an alliance to take the holistic care of the patient. So nurses and physiotherapists have to really be, glove in hand to take good care of the patient. First of all, we start with the side effects of immobility that a neuro patient undergoes. So as we know that the muscles atrophy when the patient is not using them while his stay in the ward and the ICU. The joints go into contractures, there is reduced perfusion, increased hemodynamic instability, and an increased risk for ischemia and injury to the muscles. The sarcomeres of the muscles shorten, they reduce the contracting force and strength, and slow fibers convert to fast twitch fibers. Inflammatory diseases can cause diaphragmatic contractile dysfunction, and an unloading and resting diaphragm leads to a decreased endurance of the diaphragm. There is sensory deprivation which leads to anxiety, depression and disturbed sleep. There is a sense of fatigue in the patient which leads to self-limitation. So basically there is reduced respiratory capacity and reduced muscle ability of the patient which lead to other complications. So what is the role of the rehabilitation nurse in preventing all these and to ensure that the patient ultimately goes out as a happy and rehabilitated individual? The role includes to aid in the physical recovery and promote well-being by maintaining quality of life and improving restoring function where possible, facilitate independence and personal autonomy in activities of daily living, which is sitting, walking, eating, brushing their teeth, bathing and everything. We can assist them in every way. To reduce the risk of secondary complications and related conditions, bed sores, contractures, chest infections, and to promote a holistic adaptation to related disability and limitations. So once the patient is paraplegic or quadriplegic, we have to teach them to live with that condition. They can become independent with the help of modern day aids. There are many things like calipers, and nowadays there are robotic systems which help the patients to walk. AI has gone very further today. They are helping patients to recover. So we should basically ensure all aspects of psychosocial and emotional needs also, and so the nurses should provide specialist neurorehabilitative care to both the patients and their families, because it is a very testing time for the family also. So what interventions can we do for this? So first of all, we all know that cervical collar stabilization is very important, and it has to be done even after the patient is operated and we are wheelchair mobilizing the patient. So you have to ensure that there is a cervical collar in place. The next thing is suctioning and chest physiotherapy, which I think everybody must be aware, but we will talk about it a little. The patient admitted in the ICU are at high risk of developing respiratory complications due to immobility and or the use of mechanical ventilators. Many patients are also admitted to the ICU due to acute respiratory failure. Physiotherapy is an essential component in the management of patients admitted to the ICU. Physiotherapists in the ICU aim to prevent respiratory complications from developing or mitigate the already developed problems. The most common goals of physiotherapy for respiratory dysfunction in the ICU include airway secretion clearance, maintenance or improvement of lung volume, optimization of oxygenation, and maintenance of training of inspiratory muscle strength. These general goals can be achieved using appropriate physiotherapeutic techniques and devices, which are discussed below. So whenever we do suctioning, the first thing is that we have to ensure hyperoxygenation. Pre-oxygenation with 100% FiO2 for 1 to 2 minutes is recommended before suctioning to prevent hypoxemia. Suctioning should be limited to 15 to 20 seconds while intermittently opening and closing the suction catheter without closing it for more than 5 seconds at a time. Suction can also be achieved through the oronasal route and can be used in intubated and non-intubated patients to remove accumulated secretions in the oronasal region, and that may lead to microaspiration and increase the patient's risk of ventilator-associated pneumonia. This is a suction machine. This is a chest vibrator, which I think many of you must have used. We use it to loosen the secretions, and then after that we can do suctioning. So this has to be applied to the chest on both the sides, and also it can be done by turning the patient to the side. This is a video of the suctioning procedure. So we just increase. We have to hyperoxygenate the FiO2 to 100 suctioning. So first I am doing in the elevated position only for the upper flow. Standard compression technique. So after the chest CT, suctioning will be done. So it should be done for only for 15 seconds maximum. have to drain the middle and the lower lobes. And I will remove the first we're doing the supine. So the more you sound like a drum, the better it is, it is more efficient. So this is percussion. Turn the animal. Turn the patient to the side. So we turn the patient to one side. Yeah, yes. Yes. Catheter should remain inside for a maximum of 15 seconds. Okay, so the side effects of suctioning, hypoxemia, bronchoconstriction, I think we are aware of that.
One thing was increasing the current pressure. If the pressure is very high, you cannot disconnect for a long time.
Yes.
Because it leads to hypoxia and and if you are measuring internal pressure, you will see that time you are tapping in the state, any stimulation, internal pressure will go up.
And then we can give an incentive spirometer to conscious patients. So there are two types, flow incentive spirometer and volume incentive spirometer. So volume one has been shown to be better to improve the strength of the diaphragm. And we know turning to hourly is very important. So this is a simple clock which signifies what position the patient should be in after every 2 hours. DVT pumps are important to prevent deep vein thrombosis for immobilized patients. Then you must have seen a passive active exerciser where the patient can do the exercise lying in bed, and if he is not able to move his limbs, the power is 0, then also the exerciser will do passive exercises for him. This is a passive exercise video. Can I run it, ma'am? It's just for 1 minute. And I'll demonstrate the passive exercises which have to be done for the patient who does not have control over his limbs. So it is very important to stretch the calf muscles. So dorsiflexion of the foot is very important because the foot goes into equinus and the patient is lying on the bed. We can do a few repetitions of and then we do a full knee and hip hour.
Maybe inner section of the we have a PPT, maybe we can continue this class. Dr. Carol, thank you.
The only thing is wheelchair mobilization with head support is important for these patients. And that's the end. Thank you.
Yeah.
Any questions?
Unfortunately, I don't think we have time for questions on this one. Your thing went on for quite a long time.
One comment.
Yeah.
If there is a lot of thrombophlebitis, do not squeeze on the calf muscles.
Yes.
You dislodge a clot.
Yes.
Make embolism. So do not, because we give injection, that thrombophlebitis. You do like this exercise, you dislodge a clot, that go to brain and paralysis.
Yes, that precaution is there. Thank you. Thank you.
Our next speaker is Mr. Dennis Victor. Is he here? Okay. No, he's coming. Who's speaking on care bundles. Care bundles to minimize infections in the ICU. Dennis, if we could finish in 15 minutes. You have
Yes,
20
sir.
minutes, you have 15 minutes, and we can talk about 5 minutes.
Right, sir.
Thank you.
Dignitaries on the stage, friends and colleagues, a very good morning. So I will take you directly to my presentation, and so this is the more practical approach that we will be discussing today. And I'm aware that all of you are in the ICUs, in the wards daily, and you've been doing this every day. So it's just a flash what we'll be discussing today in my presentation.
Can you have the slides, please?
Yeah. It's here. It's come, sir. Yeah. Okay, so care bundle approach. Objectives would be understanding the impact of HAIs, understanding the details of preventive bundle approach, implementation of these bundles, and focus on prevention and reporting complications to stakeholders for accountability. These are few rates that I have from the road traffic accidents. The data is from the UT Police Department, UT and State Police Department, suggestive of the burden of trauma that we have. These are normal people. These are healthy individuals who were traveling and met a road accidents, and they've been admitted to the hospital. So the numbers are
too large. So they're healthy individuals admitting to the hospital, and now we're giving them hospital-acquired infections. So, and believe me, these are all preventable things. These approach that we follow today, and we learn and we review these factors, and these are preventable things that we perform every day. And so 1.5 million people suffer from HAI in any given time. The prevalence rate, it varies, and it's approximately 5 to 25%. Kills more people than AIDS and breast cancer and accidents put together. The CDC estimates that in any given day, 1 in 35 patients do have HAIs, and research also suggests that pathogens are outsmarting the antimicrobial drugs that are present today. So having a IPC program, having a infection prevention and control program in your ICU, in your ward, in your hospital would be very meaningful, and having all these components together would bring out a better outcome. We have a trauma model that we follow. Why is it important and how does it work? We have a surveillance system. We have a active surveillance module that we follow. And these surveillances, they are outcome based and process surveillance. Outcome is when we are strictly adhering to the case definitions, and that's how we collect data, and that's how the outcome comes. And then there is process surveillance, which includes hand hygiene and preventive bundles. So our target would be the process surveillance. So between my slides, we will stress upon the preventive bundles today. So preventive bundles for VAP, CLEPSI and COTI, ventilator-associated pneumonia, central-associated bloodstream infections, and catheter-associated urinary tract infections. So what is a bundle approach? These are collective evidence-based practices that we put together, bring out a better outcome. So these are preventive bundles that we put together. These simple activities that we do. We put them all together in a place. We perform these activities practically. In turn, we have better HI rates. Okay, so we have reduced HI rates, I would put it like that. This is the minimum standard of care that we follow, can be used as an audit tool, and this is the best practice that we follow. As we all know, what is VAP, how the rates are calculated. Again, this is the algorithm that we usually follow here at Trauma Center, the checklist for data collection, but the target is this. So how can we prevent VAP? Simple steps. I think we've been doing it, but if we put it in the bundle form and analyze what we are doing, I think we will have a better preventive strategies in our ICUs, and better quality care in our ICUs. So head and elevation, 30 to 45 degrees, daily sedation vacation. So we stop the sedation, check the GCS, see if there is a need for further ventilation. Of course, assisting with the physicians or the clinicians in the particular ICUs you're working. Peptic ulcer disease prophylaxis. So the pictures are there, head and elevation, and fentanyl infusion, sedation, or whatever sedation is in progress in your wards or ICU, in your ICUs. Use of systemic antacids, and then use of DVT pump, pressure bandages, and use of heparin. So these are the bundles. I'll explain further how do you put it in a chart, and you can analyze these things. With these preventive bundles, there are a few more suggestive things that can be done and put together to have a better outcome. Care of ventilator tubings, use of water trap chambers, see that there is no humidifier vapors in your tubings. If there are, let's take them out every 2 hourly, monitor them, check them, and sterile suction techniques. closed section, of course. Practically, I am sure we suffer a lot when we have closed sections, but again, having a sterile technique is more important for the prevention of VAB. And of course, the oral hygiene that has to be maintained every 2 hourly. With normal saline, the latest guideline says you need to use normal saline every 2 hourly. Benefits, believe me, it will have a better outcome on your VAP status and even the patient outcome. And so this is the VAP bundle that we follow, and then comes the CLEPC, central line associated bloodstream infections. That's how the rates are calculated. There are a few checklists that we follow here. Okay, so what is this is again, this is the bundle that is to be followed. Most importantly, hand hygiene. We've heard it every now and then. I think I can only stress more on hand hygiene because it's the single most important factor that reduces HAIs in any given time, any given place. Next comes the barrier precautions upon insertion and manipulation. So in case we are manipulating, in case we are administering medicine to our patients having central line, make sure we use appropriate PPE, scrubbing the hub. That is the more important. We'll know what the scrub the hub is. So on manipulation, whenever you're giving medication, hand hygiene, wear sterile gloves, use sterile cotton. The port has to be rubbed, rotate alcohol with 70% alcohol, rotational frictional rub for 15 seconds, and then administer let it dry, let the alcohol dry. Make sure we are not using sterilions or anything which has emollients because it doesn't dry. Use 70% alcohol and then scrub the hub 10 to 15 seconds, rotational frictional rub, and then you're ready to administer your medicines via the central line. As soon as you administer, you can close the port. So it is as simple as that. We've been doing it day in, day out. All we need to do is just follow a few more steps that can prevent infections. While insertion, we need to take care of the skin antisepsis. Chlorhexidine 2% is recommended. You can also use alcohol 70% and providing iodine. Optimal catheter site selection, that particularly means that jugular vein and subclavian veins are a better site to be inserting CVCs than the femoral catheter site. And then daily review of necessity of lines. We usually visit ICUs, we usually visit patients with central lines in the wards also. Sometimes we see a peripheral and a central line together. So that's the time we need to intervene as healthcare workers, as efficient nurses, that okay, why does this patient have a central line and a peripheral line? When it's not required, it's no more needed. We can always talk to our physicians and do what is required, either the central line or the peripheral. If it's required, well and good. If not required, we can take off one line. Okay, so along with this, as we discussed, hand hygiene, don sterile gloves, this is the scrub the hub technique that needs to be followed. And you can have a red flag in your ICUs, people with patients with central line, and these are the scrub the hub techniques that are needed to be followed every time. Will help you reduce bloodstream infections. Okay, then comes our catheter-associated urinary tract infection. That's how the rates are calculated. Checklists that are followed. Again, the target, the bundles that need to be followed. Aseptic insertions. Please, I request and I urge that every time there's an insertion taking place, please supervise. Okay, whether we are senior nurses, somebody has to supervise every time because patient would require privacy. Patient, there is a much requirement for need to see the sterilization technique, need to see the insertion technique being properly followed, and that's why nurses are therefore to have an efficient delivery of care to the patient. and proper maintenance. We usually forget while maintenance, just catheter, it's supposed to be hanging in there, but not on the floor. Usually you'll find the floor and it will be there on the floor if the helper is there to help, or if the patient attendant comes in, we probably would ask him to do it, but simple steps, it shouldn't be on the floor, the spigot has to be closed. Simple steps, we see it every day, has to be hanged below the waist, below the bedside, it has to be closed dependent, the circuit has to be closed, the drainage has to be dependent. So again, that's why we've been trained to do this, so we need to monitor, supervise all these things. And on the third day, we can assess if there is a further requirement for indwelling catheter. If it's not, we can request if the patient's conscious oriented and doesn't require catheterization for longer than that period. Soon, we need to be proactive. We need to be prompt to tell our physicians, tell our SRs that okay, I think this patient can void. We can ask the patients, we can talk to the patient. Are you willing to let it go? Let's give it a trial, and then we can give them some bladder exercises, and then we can promptly remove these. This can be done. This is doable thing, and then daily assessment for prompt removal. Okay. And what also needs to be taken into consideration is that the person who is again supervision. We have a multidisciplinary role in nursing, so this is also important. And the sanitary worker who is helping us to remove the urine from the bag, we need to be that the person also needs to be trained. And who will train him? Of course, you are there, been in ICU for a very long time. Even not for a very long time, even if you're there in a day, this is the practice that is, minimum amount of, that's the amount of care that we are willing to give. Hand hygiene, estimate the volume for appropriate measurement, open the port, drain the bag, hand hygiene. We need to train the person. Okay, once you've emptied, once you've measured, the spigot needs to be closed, and then he needs to change his gloves. He needs to go through the urine, and then he needs to change his gloves and do hand hygiene, and then go to the next patient. Simple steps, we've been seeing it, observing it every day, but it's time that we really look into this, these small simple steps. So this is the chart that we follow, the compliance checklist. So every time the compliance is yes, every time somebody does hand hygiene for central line, the first bundle is for central line, so we put on yes. They, upon manipulation, they used minimum barrier precautions, yes, yes, yes. So subsequently the yes is put. The red circle that is there is non-compliance. So if there's one no in the whole bundle falls. So that's why I've written CBC 4 by 5. So in end of the month you can calculate your numerator and your denominator, and then it will give you the compliance rate. It will give you this is how what the compliance is of your ICU, and whether we need to look into our practices and redo and then reassess what we are doing is beneficial or not. So that's how it can be worked. Similarly for ventilator and for bladder bundles. So this is a closing proforma that we use, and in the bottom there are that's how we put our compliance, and then percentage is taken out for our own ICUs. So again, it cannot be done. Process surveillance cannot be completed without hand hygiene. Naked eye observations, CCT observations. That's how we do it here at Trauma Center AIMS. Motivating people to talking wall, placements of hand.
Dennis, can you
yes, ma'am.
just conclude?
Yeah, it's almost done, ma'am. Okay, so generation of reports is very important, because that's how you will analyze and assess that, okay, where the benchmark is, where we stand, and where we need to progress. This is how we take out our monthly reports, and this is how we take out our compliance bundle percentage, an average for various areas. And This is the hand hygiene compliance that we take out every month for all cadres of healthcare workers. It's not specific to a specific cadre, it's for everybody. And for hand hygiene, Trauma Center won the Asia Pacific Hand Hygiene Award in the year 2015. And it all comes down to until we distill into practice. It will only be completed if we distill it into practice. Thank you so much. Any questions?
Yeah, thank you, Dennis. That was impressive, but I think maybe a little too impressive. People who come from centers which don't have as much HICC backup and as much thing for you, you haven't told them what to do. I come from a hospital, no, not me personally. You come from a hospital, say a 300-bed hospital. You've got 120-bed ICU. Are you going to have all those compliances, the generation of reports and all that? You're not going to.
That's fine, sir. That's
so
fine.
What should they do then?
What can be done on level 1 trauma center, level 3 trauma center, level 2 trauma center, at district level? Because there are a lot of people come from small place.
Could be coming from resource crunch and not from periphery hospital. I think as he has mentioned it, hand hygiene is the single most powerful weapon to reduce infection in your patient. So hand hygiene, you need not have those high-end alcohol hand rubs. It can be done with simple water and soap. That can also be followed. And really, about knowing the generation or report, maybe this can carry forward in case you start really looking into your infection rates, or if you're really interested in bringing out as a nurse or as a healthcare provider where you stand, maybe if you correlate your hand hygiene practices with your patient outcome in terms of your infection rate or something like that. I do not say you start off with the whole hospital. Maybe you can pick one of your ICU, one of your HDU. You start off, take a baby step, and then it can, I think, the process can follow. And it is, again, as it is said, and it is a nursing conference, it is a nurse-driven activities. If you have the will, and if you have the zeal, and if you have the conviction, I think you all can do. Yeah, any question? Any question, please?
Thank you. Since we are talking about COTI, catheter-associated urinary tract infection, nowadays we have we have two types of Foley's catheter, right? This urine draining catheter. One is silicone and one is Foley's rubber one. So since we are taught that silicone, we cannot prick the silicone catheter since it is not recoilable, and rubber is recoilable, so we can use needle aspiration for the Foley's. So I have a doubt that how to, is it correct way to disconnect the catheter and take the sample through the silicone catheter? We are the catheter we are exposing more.
Okay. So
I don't know whether this.
Okay. So so we're mixing two different things. Okay. Yeah. That's the sampling for that's for collection samples. For we'll discuss it. I think we don't have options if we're using a silicone catheters, of course, except for this, you rub it with alcohol, take your samples, clean it and put it together. There's no other option for doing it. So that's for sample collection. Para bundles, for bundle approach. So those are the activities that we use for prevention. So it has got nothing to do with sampling. Okay, so two different things.
Yeah, I think we'll conclude.
I think
we can answer later. Maybe
Yeah.
I'll talk to you because this is a big hot question always. Okay. So thank you, Dennis.
Thank you.
Actually, I also, because they are talking too much, there is no time for discussion.
Yes.
They should reduce the time of
Yeah,
10 minutes to
which
10
is-
minutes, 5 minute discussion. 10 minutes talk on 5 minutes, because if they want question and then answer, it's only lectures, there is no discussion. So I think this 15 minutes must be 10 minutes. That all consumed by the speaker.
So the next speaker is Mr. Rakesh Kumar Yadav.
12 minutes, 10 minutes.
You'll have only 10 minutes,
No,
sir.
yes, yes. So he has a 20-minute
Yes,
talk.
sir.
He has a 20-minute talk, so 15 minutes. Right?
Yeah.
Okay, so try to conclude, sir.
15 minutes talk, 5 minutes.
You can start, sir.
Okay. Good afternoon, chairpersons, respected faculties, and my dear friends. Today my topic is, you all are aware, and it is a day-to-day practice. You all do the daily in each and every shift. That is, please slide please. You are handing over, and you all know how to do it. Some way, when you are taking the handover, you are in peace mood, like you are not in hurry, but you are giving handover, you are in hurry, jaldi se karke mujhe ghar jana hai, right? So that's the difference, because one person is in hurry, another person is relaxed. So when we are handing over, we forget to tell many things. Sometimes it's happen, and if we really forget some important points, this can lead to some like disabilities and can loss of life. It can happen. So as you can see in this picture, there are a lot of tubings, monitors, ventilators, and just suppose you are handing over this patient to the another one. Is it possible to remember everything? Because we are giving like just quick handover. Is it possible to remember unless it is in a structured way? If it is in structured way, you can hand over properly without forget something. So the clinical handover is one of the most critical steps in patient journey, and it is a core skill that need to be taught to the health professional, student nurse. Clinical handover should ensure that the lapse in the continuity of the care, error and harms are reduced in the hospital and the community setting. Handover, however, is often poorly performed, that you all maybe agree, which is critical details being omitted and irrelevant details included. Although the process of handing over between the shifts has been embedded in nursing practice for many years, the changing pattern of the work in the hospital setting means that there may be different medical teams looking after a group of patients across a 24-hour period. Neurosurgery patient vitals and conditions change rapidly, and it need to be kept in keen observation, and vigilant handover need to be given to prevent disabilities and save patient lives. Definition: handover is a exchange between the health professional of information about a patient, accompanying either a transfer of control over or a responsibility for the patient. And the handover can be between the shifts, your morning, evening and shift, night shift. It can be intra-department when patient becomes sick, or when you patient shifting from ICU to the ward, you are handover to the doctors also. So there are some key factors that we will discuss. So if you go according to that, so it will be in a structured way, and there is a less chance you will forget something. You all know that types of handover: bedside, verbal, non-verbal, and somewhere it can be discussed like tape. You tape in mobile, you keep some recordings, and the other one listens, but it is very less practiced. What are the importance? It enables you to properly transfer patient information, responsibilities and accountability to a new person or team. Because the newer person came in the next shift, he maybe not know what is the patient having, what has been done, what need to be done. So if you got the proper handover, he come to know the everything. It shorten the time spent and changing up patient information, delivering care. A handover requires a nurse to communicate objectively, appropriately and concise with the other health professionals, understand and use medical and nursing terminology. Before 1 or 2 months, I was taking the handover from my juniors. So in the mechanism of history, they have written in mechanism history of FFF. I scratch all my mind. What is FFF? What is this mechanism? Later on I ask you, what is FF? Sir, fall from first floor. So never use this terminology, right? Interpret charts and other documents, write up patient observation and understand clinical procedure. Technique, definitely you need some techniques to proper handover. You have to be organized, you have to prepare your handover. Stay focused on the particular points, because in your 6-hour shift or 12-hour shift you have done a lot to the patient. You need not to discuss everything, just what are the points you need to tell the patient, just stay focused on that only. Then communicate clearly. Sometimes हम बोलते कुछ है, सामने वाले को समझ में कुछ आता है, तो the message should be given like कि he should understand आपने क्या बोला है. Be patient centered only and allow proper time. These are the key areas: time and place, delivery and the contents. In time and place, you note down the handover. Better if you note down something, because if you listen, there might some chance you forget something. So better note down the points what you need to be done in your next shift. The handover should take place during work time. Handover will usually occur 3 times a day. Host the handover in a location where you won't be interrupted. There less shore come or less disruption or, and host it at the better if you host it at the bedside. Delivery, you have to be prepared before the handover. Avoid the consistent format. There are many formats. If you go to hospital, there are like IPA, SOAP, SABA, there are many formats you are handovering to the patient. Although I am very less place I have seen ki they are using this format. They simply, we have made our own formats. If you go to the hospital, they have their own formats like ABC formats, many formats are there. So whatever your institute say, but it should be in structured way, that nothing should be lapse. Avoid complication diagrams that I told you, FFF and like unclear observations, and you have to be leader. The content of the like patient identification, the UHID number, location, your bed number, issues, and the condition, their status, what action you have done your shift, when you are anticipating the needs, what are the medication patient are on, what are need to be like days of the medication, antibiotic days, and when it should be stopped, if something special medication, what are the things you have to tell the clearly. Relevant background of the patient, personal information, and any issue you want to discuss with the patient especially, then you can discuss, and what are your recommendations. Then these are the issue chart. You are the neurosurgery issue nurse must be know it. So this is a chart. So if you go to some hospital, like they may have their ICU charts. They have in our trauma center, we have in front we have the nurses note. So on the nurses note we have the TPR chart. TPR chart, on that we have written the patient diagnosis, post-operative days, what are the operations have done, bed sores, and day of antibiotics, what are the tubing. So everything is mentioned on the front on that TPR chart. The next is the nurses chart. You all know the medications. And next is the ICU chart. It is being done second hourly. You all know it, like time, BP, pulse, mean arterial pressure, saturation, ICP, section, everything. So just if you prepare beforehand, so you need कि आपने क्या छोड़ा है, क्या आपने अभी नहीं किया है. So if you check it, so you will keep in your mind. Then this is the current status chart. This is very good chart that we discuss that we are doing in our trauma center. So it's include it is doing the shift wise. So in each day you have seen the ABC, like morning, evening, and night. So what are the problem patient have, the last CT, because if you see when was the last CT done, you will go to the PACS and search when was the last CT done. So if you simply this chart, how many times the CT has done, last time when was the X-ray done, what are the culture reports, everything you can see on this chart. Then tools, there are some standardized tools like SBA, that is situation, background, assessment and recommendation, that we'll discuss later. IPASS, this is illness, severity, patient summary, action list, situational awareness and synthesis. Then SOAP, subjective, objective assessment and plans. So we'll discuss the SABAR only. SABAR is a structured method of communicating clinical information that require immediate attention and action. SABAR improve communication, effective escalation and increase safety. It used well established in many settings, not in the nursing also, it is also used in the military also. And it has 4 steps: situation, background, assessment and recommendations. Why we use SBA? Simply it can be like whatever that we can give the over through the nurses note only. Why it is being needed? So to reduce the barrier to effective communication across different disciplines, because some may be are familiar with the charts, but some may be not. So, and Sabha create a shared mental model around the all patient handoff and situation requiring escalation or critical exchange of information. Sabha is a memory prompt, easy to remember and encourage prior preparation for communications. Sabha reduces the incidence of missed communications. So if you discuss that Sabha, first one is the situation, like I want to hand over to the ward to the ICU. If the patient suddenly deteriorates, GCS goes low, ICP goes high. So like I am Rakesh, nursing officer of TC5 ward. I am calling of so and so patient. I am calling because the patient increase ICP or what are the patient issue have? Maybe hypotension or temperature, other one is whatever. So this is the situation. This is the situation of the patient. Background is like patient in background we can discuss patient admitted with the what history, what are the procedure has done, what are the tubings patient may have, what are the since how long the condition has been changed, and what was the last vitals you have been observed, and any medical and surgical history. So this is background. If you discuss these things, so it's cover all the things. Next is the assessment. Assessment is like what is your assessment? Why this problem happened? Maybe you can assess it, or sometimes you have no idea why this happens. So just what are your thought process say it had been done due to what reason? So that is your assessment. Then recommendation, why you are shifting the patient? If you are calling a doctor, why are you calling him? What is the reason for that? And in how much time you want doctor or to the next ICU ward to be get ready? You want to shift the patient. So tell the approximate time. It is not like we are shifting one patient, so they may be relaxed, it may become in 30 minutes or half an hour. So tell a particular the time. In 10 minutes we want to shift the patient. Patient is very sick. So be particular to that. Then if you are handing over to the doctors or your resident or faculty, so just ask. Meanwhile, if you need to done something, any investigation, any reports you want, anything. So you can suggest your recommendation as well. You can take the recommendation also what you need to do. Benefits, definitely there are benefits. Making patient feel calmer and more confident in your healthcare service, keeping patient care progress smoothly, reducing the needs for the service user to repeat themselves, helping to maintain records of the patient progress, helping staff to deliver more consistent care, allowing staff to communicate issues and concern, so the next person can address them swiftly. There may be no confusion. Prompting person-centered care, saving staff time, energy, which help to prevent stress and minimize mistakes. Helping staff feel more prepared and confident to do their job. Promoting a culture of teamwork and support in your care setting. Challenge, when you implement something, definitely you might feel some challenges. It is not easy like we are planning to implement something and they will accept it. Is no. You have to continue work hard, like Dennis has said, they want to implement some infection control practice. So they are practicing hard, repeating the same thing, keeping observation on the same thing. Then the results comes. So the challenges are summarizing complex cases can be difficult for the junior staff or the newer staff. The person making a referral may be asked to repeat the information and may not get the help expected. The person receiving the referral may interrupt and make assumption about the capability of the person who are making the referral, and all registered document must be updated and completed. So this is a study that been done in Delhi. The aim was of the study to the nursing handover practice in the Neuroscience Center of India, and the study was conducted in 200 bedded public sector Neuroscience Center in New Delhi to assess the nursing handover practice across the 5 wards, all shift, weekend day and week, using a pre-test checklist. 10 elements were observed under the category of all times, duration, process, nurse interaction and the patient communication. And the conclusion was the study reveals a need for system change and the standardization of the handover. Greater administration commitment, use of technology, training and leadership development will aid to the continuity of the care, promote patient safety and ensure better outcome. So you need to be practice more hard. So like it is a simple process we are doing daily, but as you are the future nurse, we are the future nurse, so we can make an impact and we can do in a systematic way. So we can start with our wards and we can do in better way. Then when I was making the presentation, I was thinking what could be the future of the handover. Since I have joined the AIMS in 2000, since then we are on the counter, we are reading the report books, then going to the patient bedside, reading all the nurses' notes. Since I am seeing the last 15, 16, 17 years, and before that it was the same. So the thoughts come to my mind, can we have that tab over? Tab over is like you are purchasing and investing so much on the stationery. Like especially in the center where there is no issue of the funds, we can start of the tablets and distribute to the each page beds, especially in the ICUs and critical areas. But it needs more study, what are the cons and pros, benefits, and what can be like in security issues and many.
Okay, sir, could you please conclude?
Yes, ma'am.
Can you please conclude? Time
Okay,
is
ma'am.
over.
I'm concluding, ma'am. So there's not a lot of study need to be done. Then we can implement tab over if it is possible. So then one can be master tab over, can counter over, can done on that. Then patient side tab is there. So everything you are finding on the, like we are talking about the digitalization. So I think we can do the digitalization. With that I will conclude. Effective clinical handover is an essential component of safe patient care to ensure reduction in errors, patient harms, and improve continuity of the care. With rapidly changing work pattern within healthcare workforce, excellence in clinical handover is increasingly important. It is essential that healthcare leaders and professionals from across the health discipline works together to ensure good clinical handover practice are developed and maintained. Protected teaching time and resources are essential to support staff and student in this endeavor. Thank you.
Thank you so much, Rakesh sir, for elaborating on nursing handover. I think it is one of the essential thing that on every day in each shift, the nurses need to do handover the patients. Any questions from the group?
Handover is there everywhere.
Yes, sir.
Pilot is piloting from here to Delhi, Delhi to Bombay.
Yes, sir.
Then somebody will take over from Bombay to Chennai. If it doesn't hand over, and what happened? Doctors handing over. They are not very serious, right?
Yeah, the nurses are more serious.
I was in casualty ends. If you do not tell the condition of patient who is soft, multi-trauma,
Yes, sir.
So handover is a very important part of everybody's life working in the hospital.
Yes, sir.
In casualty, in the ICU, for the doctors, for the nurses, for the administrator, you know the duty of the city.
Yes, sir.
You know handover book there?
Yes, sir.
Have you gone to duty of the room? Go and see.
Yes, sir. And especially we nurses have very good handover technique, especially in our reports books, and we are very good in handover. Thank you.
Thank you so much, Rakesh sir.
The complexity and the diversity of nurses' role in healthcare signalizes the pivotal role they play in the recovery of patients.
Okay.
Next
done?
speaker.
One more speaker.
One more speaker, Srini sir. Please calling in the fourth speaker.
Yeah. Okay, so can we have Mr. Gop? Okay, Divya is doing the same thing. Okay. Sure. Okay, so Divya, please take over and do neurotrauma.
Good afternoon,
rehab.
respected speaker, chairpersons, and my dear participants. So I am a surprise speaker. So I wish I would like to take it as a discussion than more than a presentation. So the topic I am taking is nurse-led neurotrauma rehabilitation. So at the end of the session, I expect you to understand the process of rehabilitation, and also you'd be able to comprehend how a nurse-led neurotrauma rehabilitation works. So what is the difference between a neurotrauma and other trauma? Anybody from neuro side? Yes, Prince? Okay. Yes, absolutely. Thank you so much. So any trauma means it could be physical, it could be psychological. It depends where the trauma is. But when it comes to neurotrauma, all the domains like physical domain, cognitive domain, and psychosocial domain or functioning of an individual is being affected. So that the point comes why the patient needs rehabilitation. So actually, as we said, that is neurotrauma. And what is rehabilitation? the more faster you give me answers, the more fast I will send you for lunch. What is rehabilitation?
Moving the patient towards independence.
Yes.
Post-injury.
Post-injury rehabilitation. So who has to do rehabilitation? It's a teamwork. Who is the core element or who is the key person? Central involvement of the? No, one person has to be the key, has to play the key role. So it is the patient. Rehabilitation is always, it's not what is done to the patient. It is what we, rehabilitation is not done by the patient. It is done by the patient with the help of professionals. We give support and guidance so that the patient can do by self. That is rehabilitation. So rehabilitation basically is an educational process. There is central involvement of the patient, the key involvement of the family and the carers, and there are set goals, and that goals has to be measured periodically, and as you all rightly said, it is a multidisciplinary process. So I believe to understand any concept, if we are able to answer 5 W's and 1 H, the concept is clear. What are the 5 W's? Who, why, where, what, when, and how. So let's start with why. Why rehabilitation? Sorry. Basically, we provide rehabilitation for 2 reasons. One is restoration of functions that can be restored. Whatever is bachao can be restored. And the second is learning new things differently. Like a patient is having paralysis of one side or right-handed person. So he has to learn new techniques to eat, to button, whatever he is doing with his right hand. So now when rehabilitation starts? When does rehabilitation start for a patient? Absolutely, from the time of admission. So, as absolutely, ma'am said it right.
That's the right answer. If somebody is admitted trauma center after 15 days,
yeah.
so that is the time. It
No.
should be as soon as possible.
Yes.
And maybe from time of the
Injury. Basically, when we are practically seeing, we assume that after an injury, patient comes to hospital immediately. But at the spot of injury, stabilization of the spine itself is a rehabilitation process. We are restoring the functions and preventing further injury. So at the time of injury, and maybe at the time of injury, professionals are not available. So practically, we say from admission, or to be theoretically it is from time of injury. And where rehabilitation process can be started or where it can be given? As we said, at the spot, at the injury, acute hair hospitals wherever the patient is taken at first, then multi-speciality hospitals, OPD services can be given. Nowadays we have home visits. Physiotherapy, occupational therapy, people go to home and provide rehabilitation services. So what is rehabilitation? We have covered 3 W's. 4 W is what? What is rehabilitation? What all is covered in rehabilitation? Many classes have been, we have passed through. What all comes? Physiotherapy. Yes, so many therapies have. So basically in neurotrauma we look or rehabilitate the main 3 domains the patient is lagging behind. The physical domain, physical rehabilitation, cognitive rehabilitation, and psychological rehabilitation. So some of the commonly used types of rehabilitation is physiotherapy, occupational therapy, psychological rehabilitation, speech and swallow therapy, vision therapy, and language therapy. Most of the topics I'm sure it's been covered. So now before going to the last W, who will do it? The topic itself said the nurse is leading it. So we will speak about ourselves the last, how to do it. Because it's a nurse-led neurotrauma rehabilitation, how to do rehabilitation process. So before that, to do it, we will put a scenario. 25-year-old male coming with an RTA. He has brain injury, frontotemporal bleed, massive bleed with midline shift. Then he has a right hand fracture, right leg fracture, injury to the eye, injury to the ear, coming to the casualty. So what are the steps that we have to do? I'm just looking at the point of rehabilitation process. First is initial assessment and early interventions. So initial assessment, as we all know, we are masters of how to manage a patient coming to the casualty, and in early interventions include airway, breathing, circulation, vitals, maintaining everything. So after all this assessment, it is been concluded that the patient needs an emergency surgery. So from emergency, the patient will go to OT. So in the emergency, as a rehabilitation nurse or a professional, what I have to do is the patient who is coming to us very recently had a trauma experience. So the patient is in shock. So all professionals who are working in emergency has to make sure we are providing psychological support and we are not making a stressful situation. Already the patient would be in confusion and disorientation. So we have to make that environment little calm for the patient, but still we are helping the patient. Then patient who is coming with the severity of injury is not directly proportional to the rehabilitation process. A patient might be coming with so many open wounds, hand fracture, leg fracture, so many open wounds, but and fractures. So fixing that fracture would be good enough for a rehabilitation. The patient can go home the second day or in a week. But a patient who is coming with no open wounds has a good head injury and GCS is very low. So that patient may not have that much of severity of injury, but the rehabilitation needs would be, complexity of the rehabilitation would be higher. So approaching a patient for rehabilitation is we have to individualize the care with holistic approach. So our patient, the 25-year-old male, went to OT and came back to ICU. So the second step, multidisciplinary team rehabilitation needs assessment. So in the ICU, we know who all are taking care of the patient. We have the surgeons, we have the intensive care specialists, the specialty nurses, the team members, physiotherapists, occupational therapists. If it's a well country to do, then we have speech therapists, all that therapists. Here the physiotherapist is doing all the Baki rehabilitation purpose, I feel. So all these people have their own assessment. The surgeon know, or the intensive care specialists know what to do. The nurses have their own targets to achieve. Primary care, medication, all those. So everybody is going to do their own part when the patient is in the ICU. So need assessment is particularly little towards the professional level. Then setting rehabilitation goals. As each professional we have short-term and long-term goal. The goals, short-term means if the patient is intubated, early extubation, patient should be on room air fast. So that is short-term goal. Long-term, the patient has to go home and work as to a pre-injury level. Then developing a rehabilitation plan. Since we have assessment and goals, we have to have a rehabilitation plans and referral. What all therapies has to be given to a patient. Then after making the plan, it is process. Working, now the action has to be put, programs and therapies has to be given to the patient. So it is like something is missing. The patient is there in the ICU, I am doing my part, somebody else is coming and doing the other part. So if there is a coordination of rehabilitation care. If there is a coordinator, half of the things can be sorted out. So let's see with the coordinator how things work from initial assessment. So if I am a coordinator, I will assess the patient within 72 hours of admission to the emergency, what all needs, what happened to the patient, what are the needs. Then I work as with the trauma team about the need assessment. Then I say with the trauma team and the patient, we set goals with the help of the patient, what the patient needs and how it can be achieved. Then rehabilitation plans, and then program planning and referral. Social worker has to be referred, all the physiotherapists, everybody has to be referred. Then therapy, according to the plan, we will sort it out. And during the trauma nurse coordinator has to be a part of the daily rounds. She will update what all is happening with the patient, what has to be added, what has to be reduced. Then from hospital, the patient is getting discharged. Coordinator will make a plan. When the patient comes for follow-up, again she sees the patient who has to be continued, what all therapies has to be continued, what has to be discontinued. Like physiotherapy, the patient is well enough, going back to job, physiotherapy can be discontinued. So what has to be done, what not has to be done, the coordinator can do. So who is doing? As master of all trades, nurse is the best person to carry out.
And could you please sum up, please?
Yes, ma'am. Nurse said rehabilitation can work well. These are my references, open to questions.
Anybody have any questions?
You have not spoken out financial rehabilitation.
Yes, sir.
Social rehabilitation. Because most of the trauma people are socially outcasted. They are demoralized, they are maybe physically well. Even after minor head injury, in Vietnam war,
yes, sir.
50% people, those who went back to America, they lose their job. Because they are psychosocially unfit, they are temper tantrum, they could not concentrate, so there is ultimately job loss. So they are job-oriented rehabilitation.
So
okay, not to you, Divya, just generate with the audience. I'm going to exercise the privilege with chairman and keep you away from lunch for another 2 minutes. Okay, chairman can do that, starve you. All right? So I just want to make one comment on each of these topics. Maybe I can stand up and you can see me better. Yeah, So what you must, nutrition, the first topic we had, when we write calorie orders for our feeds, I'm talking about, nasogastric feeds rather than oral diets. What are the calorie orders we write? How many calories do we write for? 2,000, 2,500, somewhere around there. What you must understand, if somebody with a head injury is posturing, M3 or M2, their metabolic rate goes up to 3.5 times normal. So the person normally needs 2,000, now he needs 6,000. Okay, think of the numbers. Please never stop at 1,500, 1,800. Give as many calories as you can. You can never overnourish an acutely traumatic brain injury. Acute traumatic brain injury, you cannot overnourish. Okay, the only problem you create is if you try to give too much protein, patients are having diarrhea. But apart from that, you cannot overnourish an acute trauma. Please remember that. Okay. Yeah, physiotherapy. What Parul said, I was very happy to see the patient being turned. Remember, when you're lying supine, when you do suction, you're taking secretions out of the major airways, right? Okay, which are reasonably in the middle of the lungs. There's lung above and lung below. Any secretions that form in the lung above, which way will they fall with your natural positioning? Towards your airways. So the upper half of your chest does not require very much chest physiotherapy, because gravity itself moves the secretions. When your patient is lying supine or almost supine, gravity moves secretions to the large airways will be sucked out. The part that needs, whereas from the large airways, secretions to the back half of the chest, gravity takes it deeper into the chest. So what you need to do is actually very minimal attention here. The major attention should be at the back, because that is where you have to bring the stuff out into the large airways. Okay, the anterior half of the chest requires very little care. Infection control. What ma'am said is very, very clear. If you want to start somewhere, start with hand hygiene. Okay, and the best way to start with hand hygiene again is empower nurses. In my hospital, the head of neurosurgery can come. If he goes to touch a patient, the nurse is allowed to say, "Sir, hand rub." And the head of neurosurgery agreed that the nurse can correct him. Okay, that's the best way, because you are the person at the patient's bedside. You are the watchman for the patient. You look after your patient properly. Make sure that the person who's cleaning the floor doesn't come and rub their pants on the bed while they are cleaning. Because they've rubbed their pants on the previous bed also. Make sure your patient's bed doesn't get rubbed on. You save the patient from infection that the next patient had. Okay, you have to be almost paranoid looking after your patient to make sure infection doesn't happen. Because infection control is a zero-sum game. You're careful 99 times. The 100th time you're not careful, your previous 99 are waste. You understand? There is no, I was most of the time sterile. It doesn't work. Okay, you have to be paranoid. Then handing over. Okay, in our hospital we have a tradition. When do patients deteriorate? When do patients deteriorate clinically? 8 a.m., 4 p.m., 12 midnight. Why?
Handover.
Because the handover time happened. New nurse is seeing the patient, getting different numbers from the person who handed over. Person handed over a good score. Now they're finding a worse score. Patient suddenly deteriorated. Why? Because the person receiving the handover did not check the GCS with the person who's giving the handover. Okay? So patients deteriorate at 8 a.m. They're very considerate patients. They choose their times. You know you have to be ready for patient deterioration at 8 a.m., 4 p.m., 12 midnight. Okay? Don't let that happen. Rehab, the easiest thing or the basic thing you have to do for your patients is one thing you want to tell the family when the patient, not in the ICU, when the patient being moved out of the ICU. The traditional thing is somebody is sick. What should you let them do? Rest. Isn't it? They should rest because they're sick. Which is the worst possible thing you do for brain injury. The worst possible thing you do is let the patient sleep all the time. The example I usually give my patients' families when I'm telling them this is, suppose your hand was fractured, it's come out of plaster. Your hand is weak. How do you make it strong?
Exercise.
Exercise. If you leave it hanging, it will get even worse. Same thing for the brain. You tell them when the brain got injured, the brain became weak. You give the brain exercise, it will become strong again. If you let the patient sleep, it is like leaving the hand hanging. Your patient will not improve. You have to drive that into their brains. If nothing else, you don't have rehab facility, you have nothing. Just make the people talk to the patient. Keep the patient awake, that helps. That helps immensely. All right? Thank you.
What you do now is you get music
Music therapy. Yes.
and you have TNS, no?
Yes.
Transcutaneous nerve
Stimulation.
music, light music all around. Most of the hospital has light music going on, right?
Yes.
So the visual and auditory stimulus. It is. Jaldi khatam ho gaya. Give them a big hand. Capture for No, it's all right. Actually, you should have more discussion. These people are not girls, boys, men, all are same. They are only onlookers. They go to the ask question, ask question.
None of them are sleeping, I guess.
You should have panel discussion actually.
Okay, sir. The complexity and diversity of nurses' role in healthcare signalizes the pivotal role they play in the recovery of patients. We coordinate and accompany the patient's journey of care, liaising with other specialties to optimize functioning and reduce disability, aiding their move towards independence. A big round of applause for our esteemed chairpersons and our very diligent speakers of the second session. It is time now for our lunch break, inviting all to partake of the very sumptuous lunch prepared just for you.
After lunch, half will disappear.
A gentle reminder, please reassemble at 2 p.m. sharp. Enjoy your lunch, everybody.
They are all waiting for that.
Please reassemble back by 2 p.m.
Ask how many are coming back.